Good morning all. Today's topic is a very important topic from the obstetric point of view and from the obstetric emergency point of view. And you all know what it is. It is ectopic pregnancy, a complication usually in the first trimester of pregnancy. Is that okay? So we'll go into the topic proper. What is ectopic pregnancy by definition? Ectopic pregnancy means implantation after fertilization. The implantation anywhere outside the uterine cavity, anywhere outside the endometrial cavity of uterus. So this is a basic definition. So why do I place more stress on this definition? Endometrial cavity. See, we can also have ectopic in the cervix. Okay, if implantation is occurring in the cervix, then that is also an ectopic. This is endometrial cavity. Fine. And say this is cervix. If implantation occurs here, it is again ectopic because this is not endometrial cavity. Let me shade the cavity. This is only the cavity. If implantation occurs here in the cornu of the tube, even then it is ectopic. You understand? Because the implantation is not in the cavity. So I repeat the definition. Implantation anywhere outside the endometrial cavity of uterus is ectopic pregnancy. Okay. Now let's go to what are the most common sites of ectopic. You all know the most common site of ectopic is a fallopian tube. Yes. So we'll go into studying some basics on the anatomy of fallopian tubes. So now let me mark the parts of the fallopian tube. From medial to lateral. We'll go from medial to lateral. See the medial most part. Now this is the interstitium. Details of all this is also taught in anatomy, but then because it's so relevant to our topic, we'll study this basic and then go into the topic. Okay, so the first part is interstitium, the medial most part. Now the second part, this is isthmus. After that, we have the ampulla. And from the picture itself, you can see ampulla is the longest part of the fallopian tube, also the widest part of the fallopian tube. So, which is the longest and widest part of the fallopian tube? It is ampulla. And you all know, where does fertilization actually take place? Fertilization actually takes place in the ampulla. Yes? Okay. And then you have the infundibulum. So, now this part is infundibulum. Yes. Following that, you have the fimbrium. Is that okay? Okay. Now let's take from this point to this point. So we have four important, leave of the fimbria. The four important parts of the tube from medial to lateral. We have interstitium. Interstitium is also called intramural part. Okay. Interstitium, isthmus, you have ampulla, you have infundibulum, and then the fimbria. Now when we take the total length, now this is around 10 centimeters. So what is the length of the fallopian tube? If someone asks you, you can easily say it is 10 centimeters. Okay. Is that okay? 10 centimeters. Now let's mark each and every part separately. The length of interstitium is around 1.25 centimeters. The length of isthmus is, say, double. You make it double. If you make 1.25 double, it comes to 2.5, right? 2.5 centimeters. The length of the ampulla, see, it's 5 centimeter. And then again write this 1.25 centimeters here. The length of the infundibulum is 1.25 centimeters. Now you add this 1.25 plus 2.5 plus 5 plus 1.25, you get 10. So it's 10 centimeters. So basically, what all the points of inference here? Someone asks you, what is the longest part of the tube? What is the widest part of the tube? What is the site of fertilization? Fertilization, your answer is ampulla. Yes. Okay. What is the narrowest part of the tube? So which one is the narrowest part of the tube? You can see here, intramural part, it is very thick because of a thick muscular wall. Narrowest part of the tube is the interstitium. Inference number 2. Fine. If they ask you which part of the tube behaves like a sphincter, which part of the tube is a sphincter? It is said the isthmus has lot of smooth muscle fibers which give a sphincteric function, which has a sphincteric function. So if they ask which is sphincter, you say it is isthmus. So these are all typical small questions coming in the exam. Okay, so this is about the basic anatomy of the tubes, you know, each and every part. So basically what happens after fertilization in the ampulla? Now the zygote moves like this and then enters the uterine cavity and then it gets implanted. The type of implantation is interstitial implantation. So when does it get implanted? It gets implanted. When does it enter the uterine cavity? On day 4 it enters the uterine cavity. Day 4 after fertilization. Day 5 it does the process of hatching. All these details I'll teach you in basics of fertilization and implantation. Just time being, remember, day 6 is the day, 6th day after fertilization. It gets attached to the decidua. Anywhere in the first 3 days, when the entry into the uterine cavity is prevented, what happens? That zygote starts implanting in the tube itself. So that leads to the development of ectopic pregnancy. Is that okay? So how does the embryo actually travel and the zygote travel? From the ampulla, interstitium, and like this. So basically speaking, what should be the most common site of ectopic? The most common site of ectopic is ampulla. The first most common site of ectopic. Fine. The second most common site of ectopic is the isthmus. Fine. The third most, sometimes this side, travel this side is also possible. Third most common type is site for ectopic is infundibulum. Least common site is the interstitium. I am talking of in the tube. Okay. In the tube, the most common site of ectopic is ampulla. Second most common site of ectopic is interstitium. The third most common site of ectopic is infundibulum. And the least common site of ectopic is the intramural part or the interstitium. Is that clear? Okay. Now, generally speaking, as a rule, the most common site of ectopic. Ectopic, I told you, implantation anywhere outside the endometrial cavity of uterus. Most common site of ectopic is a fallopian tube. So generally when we look at the most common sites, the percentages, I'll just tell you what the textbooks say. 97% of ectopic is said to be at the tubes. Okay, and we also have ovarian ectopic. We can also have cervical ectopic. We can also have cesarean scar ectopics and abdominal ectopic. So it could be ovarian ectopic, implantation in the cervix, which is cervical ectopic, implantation in the cesarean scar, which is cesarean ectopic, or implantation in the abdominal cavity, which can be abdominal ectopic. Okay, they'll never ask you the incidence of all these. All this is less than 1%. I mean, all this is around 0.5 to 0.7%. The other 3% is all this. But you should know, nowadays, the incidence of this cesarean scar ectopic is increasing because of, as you know, increasing incidence of cesarean section on the whole. Is that okay? Now, fixing it up, the most common site of ectopic pregnancy is the fallopian tube. And in the fallopian tube, we see that ectopic is more common in the right fallopian tube. You know why? Let's reason out. It is always said the right ovary ovulates much better or ovulates more frequently than the left ovary. And this is linked to venous drainage. So we all know, where does the right ovarian vein drain into? Right ovarian vein directly drains into IVC. Now this is a bigger vessel. But where does the left ovary drain into? Left ovary drains into the left renal vein. Okay, so that means there is better drainage into a bigger vessel. So now there is better drainage in the right ovary. So that means intra-ovarian pressure, fine, intra-ovarian pressure is less in the right ovary, that means the right ovary ovulates more compared to the left ovary. And for the same reason, we also find that ectopic is more common in the right fallopian tube when compared to the left fallopian tube. Sometimes this concept might also be asked. These concepts have already been asked. Now let's go into looking at the main risk factor for ectopic pregnancy. See, the most common risk factor. So if they ask you simple question, what is the most common cause of ectopic pregnancy? You will be given multiple options: contraception, surgery on the tube, pelvic inflammatory disease. Is it smoking? So your answer is pelvic inflammatory disease. Before we know how PID affects the tubes, let's study something about the anatomy of the tubes. The epithelium of the tube is basically ciliated columnar epithelium. Okay, so the epithelium of the tube is ciliated columnar epithelium. And where is the ciliary bead? The ciliary bead is towards what ostia? Uterine ostia. It's towards the uterine ostia. Now this is the uterus. Okay, it's towards the uterine ostia or towards the abdominal ostia, towards the uterine ostia. That is basically to propel the fertilized zygote into the uterine cavity for implantation. Yes. Now the tube does not have any glands. It's a very important point. No glands. You know why? If glands are present, then what happens? Secretions, thick secretions can block the tube. But instead of glands, the tube has some special cells. Now these cells are called PEG cells. Now PEG cells will not secrete a thick, the secretion is not thick. The secretion is watery. It's rich in glucose and fructose, and this is to nourish the gametes and the zygote. So PEG cells are there. There are no glands. Okay. And another additional point is, usually beneath the mucosa we have the submucosa. In the tubes, the submucosal layer is absent. No submucosa. Usually the defense mechanisms, the Langerhans, Jane cells, all those cells are present in the submucosa. The tubes lack the submucosa altogether. The tubes are as such highly susceptible to infection. Now what happens if an infection occurs? And what is the most common organism causing pelvic inflammatory disease? We have two organisms, one is chlamydia and gonococci. As such, the most common organism causing pelvic inflammatory disease is chlamydia, followed by gonococci. And other causes as well. It can even be TB, tuberculosis, salpingitis. Okay, but most common is chlamydia. So what chlamydia does now? It comes here. Now infection here mainly damages the cilia. Not only that, it leads to the presence of tubal adhesions. So imagine now, this is an adhesion here. There is a tubal block. Yes or no? There is a tubal block. Moreover, the cilia are also damaged. So now imagine now fertilization occurring here. The oocyte is released from the ovary, and then the sperm, which is a gamete cell, goes here. Now it divides itself into a, say for example, a 2-cell stage. Okay. Now it tries to travel here. It cannot move out because there is an adhesion, there is a block. There is a partial tubal block. I hope all of you are able to understand this point. Because of the pelvic inflammatory disease, there is a partial tubal block. See, if the block is complete, then that leads to infertility. The sperm never meets the oocyte. Fertilization is not possible. But if the block is partial, the gametes can move freely through the block, but the embryo cannot move. Okay. So it's a partial tubal block, and that causes, moreover, you also know what? Ciliary motility is also not there. Motility is also damaged. So in addition, there is a block, partial block. So that means the embryo cannot cross this block and cannot go into the uterus. It gets implanted there itself. This leads to ectopic. So if they ask you what is the most common cause of ectopic pregnancy, it's pelvic inflammatory disease. What is the most common organism causing pelvic inflammatory disease? Now it's chlamydia. Is that all right? Okay. We look at the other causes. Any surgery on tubes is a risk factor. What is the most common surgery that is done in the tube? Sterilization. Sterilization is most commonly done by what method? Your Pomeroy method. Can also be done by other methods like Parkland method. So many other methods. Okay. And tubal recanalization. Tubal recanalization usually done after sterilization, and that also carries a risk of ectopic. Okay, now let's learn. Now this is a very important topic, contraception and ectopic pregnancies. We do have a lot of contraceptive methods. Let me list the most common ones. Combined oral contraceptive pills, progesterone only pills. In progesterone only pills, we do have traditional POPs and newer POPs. Yes or no? Newer progesterone only pill, we are talking about desogestrel pill. All details are available on the topic on contraception. Desogestrel, in short form I am writing desogestrel, DSL. Okay, fine. We also have DMPA injection, depot medroxy progesterone acetate injection. So 1, 2, 3, and what else we have? We have our intrauterine contraceptive devices. We also have implants. Okay, now all of you please remember, as a rule, now this is an important dictum statement. Any contraception which acts by preventing ovulation. So what happens when a contraception prevents ovulation? There is no oocyte. When there is no oocyte for fertilization, understand that there is no oocyte for fertilization, where is the point of ectopic? The question of ectopic does not arise. Yes or no? Yes. So, prevents any contraception preventing ovulation, prevents ectopic. Prevents ectopic pregnancy. So now let us see here. Combined oral contraceptive pills. Take this. Combined oral contraceptive pills. Your depot medroxyprogesterone acetate, your implants, newer generation progesterone only pills. Let me shade all this so that. Now what all I have shaded here, now all this act by preventing ovulation. All this act by preventing ovulation. Therefore, they decrease the risk of ectopic. Details of all this again I will teach in contraception class, so don't worry. How does depot medroxyprogesterone act? By preventing ovulation. So they decrease the risk of ectopic. Implants also decrease the risk of ectopic. But the others, IUCD, when you take your textbook and look at IUCD and mechanism of action, it is said IUCD prevents pregnancy in the uterus. Why? Because it's present in the uterus. IUCD does not prevent a pregnancy in the tube because it's not present in the tube. Yes or no? Fine. So all these, all the other things, especially your POP and IUCD, they do not prevent ovulation. So ovulation occurs, fertilization occurs, they act by other feeble mechanisms like thickening of cervical mucus, and they are by preventing implantation. So when they act by all these other methods, what happens is the risk of ectopic increases. Okay, so questions from this can come in the exam. If you want more details on this, you can refer to the contraception topic. Okay, now smoking. Smoking is on the rise throughout the world, and now smoking is linked to increased incidence of ectopic. That is because smoking damages the cilia in the fallopian tube. Okay, so generally taking smoking and obstetrics, because this question comes again and again, comes in every topic, comes in your abruptio placenta, comes in placenta previa. So let's list out all this now. Smoking in the first trimester, it increases the risk of ectopic pregnancy. It increases the risk of miscarriages. That is, older terminology used to be abortions. We no longer use the terminology abortion. Increases the risk of miscarriages. It increases the risk of preterm labor. Therefore, low birth weight also. Fine. The women who smoke have on an average babies of weight less than, say on an average weight is some 150 to 200 grams lesser than compared to the standard. Okay, and it increases the risk of abruption, also increases the risk of placenta previa. Is that okay? Placenta previa. But on the other hand, you find smoking decreases the risk of what? Decreases the risk of preeclampsia. Okay, so what do we have? It increases the risk of ectopic. That's relevant to our topic. Okay, now the next risk factor that is discussed is ART. ART means what? Artificial reproductive technology. Yes or no? Like your IVF and ICSI. In vitro fertilization and intracytoplasmic sperm injection. In vitro fertilization, intracytoplasmic sperm injection. More details of this we will discuss in infertility. So what happens in ART? The gametes are taken out of the body, fertilized in the external environment, and then we are going to implant it into the uterus. So now imagine now, if I am going to take 2 embryos in my embryo transfer. So now what procedure we are going to do? Embryo transfer procedure. Now this is the embryo transfer catheter. We are taking 2 embryos here and we are pushing it into the uterus. Imagine what if one stays in the uterus and one goes into the tube. Now here we get, as a result of this, we get a combined intrauterine pregnancy plus what? A extrauterine or ectopic pregnancy. Now this special entity is called a heterotopic pregnancy. Now this is called a heterotopic pregnancy, especially as the incidence of infertility is on the rise. As the incidence of all these procedures are on the rise, now the incidence of heterotopic pregnancy is also is also on the rise. I hope you understand. So these are the classical risk factors: your PID, surgery on the tube, smoking, ART, contraception and all this.